Module 4B. Relaxation exercises can be another behavioral skill patients can learn to combat stress and anxiety reactions. There is much data to support that intentionally breathing slowly and relaxing one's muscle groups can significantly reduce anxiety symptoms. Providing patients with a straightforward, simple tool can be efficiently therapeutic and alliance building. For example, the patient quickly begins to see that the therapist can provide helpful skills. This can mitigate the sense of hopelessness that a patient may feel and motivate the patient to return for treatment. Remember to always provide a rationale for how the relaxation intervention can be helpful. For example, you might say, "We will learn to breathe more slowly with the goal of helping you have a tool to regularly use when you plan on fleeing an anxiety-producing situation." There are several relaxation skills that can be easily taught to your patients, including breathing retraining, progressive muscle relaxation, and imagery training. You can find instructions for these exercises in the appendix slides. It is helpful to have the patient monitor and rate their muscle tension before and after engaging in relaxation exercises. This helps provide them with evidence that they have the ability to alter their physiological reactions. Self-monitoring is also helpful as a way to measure changes over time. We will now discuss behavioral skills that can be useful to reduce avoidance. Although it is a natural tendency to want to avoid distressing emotions, thoughts, memories, or situations, we know that avoidance perpetuates all of the anxiety disorders. Forms of avoidance occur in anxiety disorders, depression, and avoidant personality disorder. Avoidance is so enticing because by avoiding an uncomfortable experience, one can temporarily feel better. However, avoidance helps to maintain anxiety in the long run. It is helpful to illustrate by looking at the experience of a patient with a spider phobia. In this diagram, we see that the spider elicits anxiety and fear. The patient chooses to run away from the spider, escaping and thus avoiding discomfort. Anxiety subsequently decreases, which is reinforcing for the patient and therefore makes it likely that he will flee at the next contact with the spider. Any type of avoidance intended to decrease anxiety thus serves to reinforce the anxiety disorder. In this slide, we examine how an avoidant safety behavior, such as sitting down in the case of a panic attack, serves to reinforce the panic disorder. When a patient with panic disorder experiences some perceived threat, this in turn may intensify the physiological anxiety reaction, and then the worries can intensify. To relieve anxiety, the patient may choose to sit down and ward off the heart attack they are fearing having. Avoidance and escape ultimately perpetuate the anxiety disorder. When a person avoids, they miss out on new and accurate learning experiences. For example, if one does not run away from the spider, we could learn that most spiders are harmless. When we avoid, we also miss out on realizing that we are able to cope with anxiety reactions, and that with prolonged exposure, anxiety reactions will gradually diminish. In other words, we habituate or get used to the experience of anxiety. Repeated and prolonged exposure help diminish distorted anxious thoughts and physiological reactions. To conquer our unreasonable fears, we must learn to face and feel them. We will now discuss the varieties of exposure treatments we can work on with patients to help them with their anxiety disorders. We will discuss Imaginal graded exposure, in vivo or real-life graded exposure, and virtual reality exposure. Exposure treatment involves gradually and systematically being exposed to situations that create anxiety. With each step one creates a new perception that one's mind and body can handle scary situations and feelings. Exposure involves taking controlled risks. To help patients learn to gradually overcome their fears, we collaboratively construct fear hierarchies of situations that can be approached systematically, beginning with the least threatening experience to gradually higher anxiety-provoking situations. Exposures may feel risky, but are aimed at teaching the patient how to tolerate the anxiety and worried thoughts as they continue the exposure. For exposure treatment to be helpful, patients should experience some anxiety. Too little anxiety will not be enough to put them in a discomfort zone. It is necessary to begin to learn that the experience of anxiety is something one can tolerate and that anxiety symptoms are not in fact dangerous. On the other hand, too much anxiety may limit a patient's willingness to stay with the discomfort. Exposures can begin as low as 5 to 10 on the distress scale, or a patient may choose to begin at their highest anxiety level. Always begin where your patient is willing to begin. Exposures can be unplanned or planned. Unplanned exposures will come up during the week, and patients should be encouraged to tolerate anxiety in these unplanned circumstances. The therapist and the patient should always be working on a list of planned exposures for the patient to work on in session and for between session homework. Patients should be asked to monitor anxiety levels before, during, and after exposures. It should be explained to the patient that anxiety symptoms will likely diminish over the course of an exposure or over time with repeated exposures. Explain to the patient that they will know it is time to move on to the next item on their fear hierarchy when anxiety level is tolerable, perhaps less than 30 out of 100. It is helpful to explain to your patient that exposure treatment is like watching a scary movie over and over. Eventually, the fear reaction diminishes and may even disappear. We call this process extinction of a fear. Also, by watching the movie over and over again, overly negative worried thoughts, like I can't cope with this frightening material, are not coming true and are not confirmed. This is called cognitive restructuring. In Imaginal exposure, patients are asked to create a fear hierarchy of feared images, situations, or memories that are graded by level of elicited distress. In session and between session exposure practices, give the patient the opportunity to imagine each item on the hierarchy until anxiety is better tolerated, and they can move on to the next item. Imaginal exposure can be a preliminary step before in vivo or real-life exposures. To begin Imaginal exposure, the therapist and the patient construct a fear hierarchy collaboratively. The therapist asks the patient to close their eyes and visualize the fearful scene with as many details as possible to optimize the sense of presence or perceived reality. Distress ratings are collected throughout the exposure by asking the patient, "What is your anxiety level now?" on a 0 to 100 scale, and recording the response. In the next video clip, we will see a 50-year-old married white female with a long history of having a spider phobia. We have collaboratively constructed an Imaginal fear hierarchy to begin in session and to do for homework. Please make sure to provide the patient with a clear rationale for why you are asking her or him to imagine distressing images. Patients will not be amenable unless they absolutely understand why you are asking them to do something that will initially make them feel more anxious. So we were planning on doing our spider exposure today, our Imaginal exposure, right?
Yeah.
Before we get to that, though, can we just take a look and talk a little bit about the homework that you worked on over the week?
Yeah.
Do you have that with you?
Yeah.
Oh, great. Okay. Let's see. So what exposure were you actually working on over the week?
I worked on the one where I'd go down into the cellar and just observe spider webs.
Okay.
Yeah.
And how did that go?
I was able to do it.
You were.
Yeah.
I see you did it looks like 6 times here.
Yep.
And then your anxiety ratings also tended to go down.
Yeah.
Right?
Yeah.
What was your experience like?
I mean, it did go down. I was surprised, but I could feel it getting less and less.
Really?
Yeah.
Good. Okay. And how do you feel about doing the exposure today with me in the session?
I'm scared.
You're scared?
Yeah.
Okay. Remember we talked about maybe doing the exposure that you have on your list of imagining that you're going out on your porch in the back and that there's going to be a spider web that you're looking at.
Right.
You're a little bit nervous.
Yeah.
I can tell. I can tell. Well, that makes sense, right?
Yeah.
Because these are things you've been avoiding for a very long time. What would you imagine would happen as we keep approaching it in your imagination for now?
I think I'll get less and less scared.
Right. Just like when you did your homework. Right? With repeated exposure over and over and over again, gradually the anxiety can come down.
Yeah.
Right? Okay. So, feel like doing it?
Okay.
Okay. There's
Yeah.
good reason to, right? Hopefully
Yep.
you'll become more flexible over time and overall have the freedom to be able to go places without having to worry too much that spiders will be everywhere.
Yeah. Yeah.
Okay. Excellent. So what I'm going to ask you to do actually is to, like we have talked about, is to close your eyes.
Okay.
Okay. Now I'm going to be taking you through the exercise. And I'm going to narrate the scene for you that you're going to be approaching. All right? And every so often I'm going to ask you for your anxiety rating on a scale of 0 to 100.
Okay.
Okay, so 100 would be your highest anxiety and 0 would be your lowest.
Okay.
How are you feeling right now if you had to give it a number?
About 40.
About 40. Okay, so that makes sense. You have a little anxiety because we're just getting started. This is a new exercise for you, so that makes a lot of sense. Okay, let's take a little time for you just to get in touch with the sensations of your breath right now. Just clearing your mind and just focusing on your breathing. Just letting thoughts come and go. No need to dwell on anything. Okay. Now I'm going to ask you as best as you can to try to visualize your back porch. You've described it to me many times. Really try to go out onto your back porch and look all around you. Can you visualize your porch?
Yep.
Okay. And maybe about 10 feet away from you, you see in the corner of your porch, you see a large spider web.
Yep.
And in the spider web, there's a medium-sized spider just hanging out. Can you picture that?
Yep.
Yeah. And how are you feeling right now in terms of your anxiety? If you could give it a rating.
About 80.
About an 80, okay. And are you having any physical sensations?
Yeah, I think my heart's beating faster.
Your heart's beating faster, okay. All right, so what I'd like you to do is just sit with that anxiety. There's no need to run away from it. Just pay attention to how your body feels, all the while continuing to look at the spider web. Notice the design of the web, paying attention to the pattern, noticing whether the spider's moving or not. At the same time, you can also notice your feet on the ground, maybe the gentle breeze in the background. Maybe the breeze is making the spider web move back and forth. And just make sure you continue to focus on the web. Can you give me your rating now?
about 60.
About a 60. Okay, so good. It's going down. Do you feel a little like you could walk a few steps towards the web? Or one step at a time?
Yeah.
Yeah? Okay, so try to do that in your imagination. Recognizing that you may have your anxious thoughts, and your anxiety may rise, but just stay with it. What's your rating right now?
About an 80.
About an 80. Okay. Can you see the web in front of you?
Yes.
You can. Good. Very good. You having any worried thoughts?
Just a little bit, I guess.
Just a little bit? Okay. You don't have to tell me what the worried thoughts are. Just notice them and then return to watching the web. Noticing the spider moving, creating his web, doing what a spider does. Just notice it. It's just hanging out right there on your porch. Feet are on the ground. Trees are in the background. Still breathing. And where's your anxiety at now?
About 60.
About a 60. Okay. Now we had talked about maybe taking one more step towards the web for this exposure. Do you feel comfortable doing that now?
Yeah.
Okay. Remember, we're moving forward in spite of the anxiety. So how about you take one more step? Now you're closer, so you can see a little bit more. More of the details of what the spider looks like. More details about what the web looks like. Okay. See that you're breathing a little bit more shallow.
Yeah.
Okay. And those are just physical sensations of anxiety. Let's just try to stay with it. Do you have any urge to want to stop or leave the situation?
Yeah.
Yeah, okay. So you're allowed to have urges and desires to flee, but we're just going to stay with it. Okay. We'll hang out for a little bit longer, and then we'll talk. Okay. Where's your anxiety at now?
Maybe 70.
About a 70. Okay. Let's give it a few more minutes. Really continuing to notice the spider and its web. Can you tell me where you're at now?
About 60.
About a 60. Okay, very good. So now what I'd like us to do is just sort of gradually open your eyes. And you're back here with me. How was that for you?
Okay.
It was okay?
Intense.
It was tense, yeah. Yeah, well, you did great.
Yeah.
Yeah. So just like in your homework, you could see, right? Your anxiety was still there, but you could see it creeping down, it looked like. Yeah. All right. So we'll keep doing that, and I guess I would hope that this would be something you'd be willing to do for homework as well.
Okay.
Okay. Visualization, and then also doing some more things that we have on your hierarchy that you can do in real life. Okay?
Yep.
Great. In this slide, we see a sample fear hierarchy for a patient with a fear of flying phobia. This is a 10-item fear hierarchy from least anxiety-provoking situation, rated 10 out of 100, to most fear-provoking, rated 100 out of 100. The goal is to have the patient imagine each item on the hierarchy until they are comfortable proceeding to the next item. There is no absolute time frame for progressing down the hierarchy. The therapist must balance the patient's readiness to move forward with the knowledge that it is sometimes necessary to gently push someone forward when fear and a desire to avoid are taking hold. In vivo or real-life exposures also begin with constructing a fear hierarchy collaboratively with the patient. This type of hierarchy includes creating a real-life, graded anxiety-provoking situation or behaviors which the patient can approach in session or for homework between sessions. Distress ratings are collected before, during, and after exposures. You can have your patient construct and work on multiple hierarchies simultaneously. For example, a patient may be trying to overcome a fear of flying at the same time that they are also working on overcoming a social phobia. There are some recommendations or tips that can be helpful to provide to your patients trying to work on graded exposures. First, the therapist can help the patient create a specific exposure items like spend 20 minutes at a neighborhood party before leaving, instead of a vague item such as stop being afraid of social interactions. Make sure to troubleshoot with the patient about possible interferences to exposure items. Plans can change and worried thoughts pop up, so it is always helpful to have a plan B or have a strategy to challenge worried thoughts. It is also helpful to ask patients to compare predicted anxiety levels with actual anxiety as they conduct an exposure. This helps the patient recognize that they may overestimate the distress they feel and that they can begin to feel more comfortable with repeated exposures. Make sure to collaborate with the patient about plans for approaching more difficult items on their exposure list. The following are some examples of worthwhile targets for exposure hierarchy types of items. The feared or avoided situations contributing to a specific phobia. Obsessive, intrusive, or unwanted thoughts contributing to obsessive-compulsive disorder. Ruminations and worried thoughts contributing to generalized anxiety disorder. Social interactions or social mistakes that patients may fear making in social anxiety disorder. Public speaking for patients with public speaking and social phobias. Feared physiological sensations for patients with panic disorder, post-traumatic stress disorder, and social phobia. Being away from safety people or situations for patients with panic disorder and agoraphobia. Being in situations where escape is difficult for patients with agoraphobia or claustrophobia. Feared memories or images for patients with post-traumatic stress disorder. And spending time alone for anxious and dependent patients. Remember that each patient is different and a fear hierarchy must be individualized and created collaboratively. Keep in mind that exposures are difficult for patients. They must fully understand how this intervention will be helpful to them in the long run. Even motivated patients sometimes have difficulty following through with exposures. They will want to avoid or escape discomfort. You can help them be aware of how to stay in the moment of the exposure by identifying the common ways that they avoid feeling uncomfortable. The following are some potential avoidance strategies that patients often use that ultimately reduce the effectiveness of their exposures. Patients will use alcohol and drugs, both prescribed and unprescribed, to reduce discomfort and affective arousal. Patients will also use all kinds of distraction like talking with someone or listening to music to reduce discomfort. Distraction also helps patients get through their discomfort But research has demonstrated that tolerating the discomfort without any form of avoidance ultimately leads to better treatment outcome. Patients also engage in internal avoidance, such as daydreaming or zoning out. They may avoid anxiety by taking safety precautions, such as sitting near exits, aisle seats, looking for locations of exits, etc. Sometimes in the case of a contamination phobia, the patient may calm themselves by planning to wash or decontaminate after the exposure. It's helpful to encourage patients to stay in the exposure situation as long as possible, or until anxiety comes down to a manageable level. It is, however, okay to temporarily retreat from the exposure and then plan on re-entering the phobic situation for further exposure. For example, if the patient's anxiety level reaches its maximum level very quickly, he or she may choose to tolerate the discomfort or briefly retreat and re-enter the exposure during the same exposure exercise. In the following video clip, we will see an example of using exposure with a patient with obsessive-compulsive disorder. This patient is a 27-year-old single white female with obsessive-compulsive disorder since childhood. Her obsessions include worries about being psychotic, having aggressive thoughts, and worries about her sexual orientation. Currently, the patient is specifically worrying about her relationship with her new boyfriend and escalating fears that her curiosity about his ex-girlfriend is an indication that she's crazy. Her compulsions, which she engages in to decrease her anxiety, include reassurance seeking, researching topics online, ruminating, and confessing. The exposure suggested for this patient involves not engaging in her compulsions, allowing her the opportunity to sit with the anxiety instead of running away from it. This can lead the patient to eventually feel more comfortable with experiencing anxious feelings and worries. Exposure also has the effect of challenging the worried thoughts and diminishing their importance and credibility.
I keep being worried, and I can't stop worrying that my boyfriend still wants to be with his ex-girlfriend.
Has anything happened that would make you think that?
No, not really. I did see her out last week, and ever since then I can't stop thinking about her or having these worried thoughts. And then I'm worried that just having these thoughts means that I'm going crazy. And my boyfriend's great. I mean, he really hasn't given me any reason to worry about this.
Okay, so it sounds like you're having two different kinds of thoughts. One is that that your boyfriend may be interested in the other girl, his ex-girlfriend, and then the other worried thought is that that means you might be going crazy. Do you think those kinds of thoughts are obsession types of thoughts, or do you think that they might be valid, reasonable thoughts?
Well, no, I mean, logically I know they're not accurate.
Okay, so we've talked a lot about trying to pause and label the thoughts, either saying those are my obsessional thoughts or those might be just my wacky thoughts. Do you remember us talking about that? Yeah. And then practicing not to engage in the compulsion of trying to get reassurance.
And I was able to do that. I mean, I did go practically the whole week without questioning him about it or even letting him know that it was worrying me.
Okay, and then what happened with your anxiety?
It did go down. It actually did go down, and we had a really good week together, and we were able to have some good times. I was able to focus on the moment, and then we went for a walk, and I ended up telling him what was bothering me.
Okay, and then what happened to your anxiety?
Well, at first, it was fine, but then it ended up being much worse, and, now he's mad at me because he's wondering why I could even think that he would want to be with his ex-girlfriend.
Okay, so this is a great example because you now have the experience of knowing what happens when you don't respond to your anxiety and you just sit with it. And then you also have the experience of knowing when you get the reassurance and you seek the reassurance and you try to reduce your anxiety, that in fact your anxiety comes up stronger. All right, and we're working on you being able to just label the worried thoughts for what they are and then sitting with that anxiety so that the worried thoughts start to fade out and they're not as salient anymore.